Hello and welcome to this session of the Center for Podiatric Education. This lecture is one that is being prepared for the New York State Podiatric Medical Association. I had received a request to cover this topic, and I thought it was an interesting topic and one that I thought deserves a little bit of discussion. And that is the discussion of continuing antibiotics after performing a surgical procedure. It is known that many doctors do this. I asked the residents several weeks ago, how frequently do you prescribe antibiotics that a patient will go home with after surgery? And I asked a number of the residents, and I think they have a good feel for what goes on. And they said probably 50 to 60% of the time patients go home with an oral antibiotic prescription following elective surgery. Now we're talking about clean cases, not clean contaminated or contaminated cases. We're talking about bunionectomies and hammer toe corrections and flat foot corrections and so forth. And again, they say 50 to 60% of the time patients go home with a prescription for an antibiotic. And apparently this has become so commonplace that I was asked by the scientific committee at the New York State meeting to take a look at this and make some commentary on it. We never think about it, but antibiotics have contributed a lot to surgery. There was a time when antibiotics weren't available, or the antibiotics available were quite limited, and as a result, elective surgery was not commonly performed, particularly on bones and joints, for fear of an infection, because if one got an infection, particularly osteomyelitis, there was little way to control it, and we simply didn't have antibiotics. I had worked my way through school as an operating room technician and as a scrub nurse, and I remember very, very well early in my career that orthopedic surgeons with whom I worked were obsessed with the no-touch technique, and it was strictly verboten to stick your finger into a wound. You only touched with instrumentation, and that's just the way it was. And much of the early history of orthopedic surgery was characterized by minimal incision surgeries, again in an effort to minimize the risk of an infection. But as you can see from this quote from the Johns Hopkins Medical Journal, antibiotics supported the advancement of modern surgery more than anything else, because now we approach surgeries and know that if there is an infection, we have the ability to control it in addition to proper other assessments and techniques, with the use of antibiotics, so we don't have that great fear of performing elective surgery as was once done. A friend of mine had a great quote. He said, "You know, Alan, there's two things that surgeons hate to see: post-operative infections and seeing patients after surgery." And I think that was probably a great quote. So the reality of practice is, regardless of what the literature tells us, that foot and ankle surgeons commonly use prophylactic antibiotics following surgery, and they'll use these for days following surgical procedures, even though we have clear guidelines as to when perioperative antibiotics are indicated. So no one argues that with an implant or with hardware or in certain predisposed patients that prophylactic antibiotics are indicated. But conversely, we see doctors who administer antibiotics routinely on all surgeries, including clean surgeries, and will continue the antibiotics for days following surgery. Now, in reducing the risk of an infection with surgery, obviously there are many, many factors involved. Proper patient selection. We know that doing elective work in patients who are immunosuppressed, patients that have poor skin quality, patients with congestive heart failure, patients with poorly controlled diabetes and so forth, are expected to have a higher risk of complications, including infection. We certainly want proper skin preparation, use of clean instrumentation, sterile instrumentation, a proper surgical environment, good technique minimizing trauma, and avoiding urgent surgery in patients that have metabolic disorders that ought to be corrected and can be corrected prior to surgery. And antibiotic prophylaxis is certainly a part of this. In looking at the classic description of determinants of infection following surgery, we know that microbial concentration is number one, so that the more germs that enter that wound during surgery and the more virulent those bacteria, the more likely we are to have an infection. Conversely, working in a clean environment, working quickly and efficiently, irrigating wounds, doing what we can to minimize that concentration of bacteria in the wound is helpful in reducing the incidence of infection. We know that resistance to antibiotics makes a difference, so that introducing bacteria that are more resistant, for example, MRSA, multi-drug resistant, gram-negatives and so forth, increase the risk of an infection. We know that the more tissue injury there is, the more receptor sites are created to which bacteria can adhere and colonize and grow and invade and infect. And we know that the more foreign materials that are introduced in a wound, the more likely one is to have a post-operative infection. Conversely, we know that the healthier the patient, both locally and systemically, the greater the immunity that patient will have to infection, the better they are able to control any contaminating organisms, and certainly prophylactic antibiotics are accepted as reducing the incidence of infections. So we want to use prophylactic antibiotics in appropriate patients. Generally, they are administered within 1 hour of surgery and discontinued within 24 hours. Our use of prophylactic antibiotics is still based on the classic work of Burke, who introduced staphylococcal inocula to wounds on the back of guinea pigs. And what he showed was that once the wounds were inoculated, he looked at the relationship of the growth of those bacteria to the time of administration of the antibiotic. So the staphylococci were administered into the wound, and of course there was growth of bacteria in the wound. If antibiotics were administered within 1 hour, we had a certain amount of growth of bacteria, and the later the antibiotics were administered, the greater the growth of the bacteria. So that we know that the antibiotics are most effective if they're administered and in the wound at the time the incision and dissection is made and the dissection is performed. But we also know that there is no data to really support the use of antibiotics beyond the immediate perioperative period. So this was a survey of members of the American Orthopedic Foot and Ankle Society, and it was kind of interesting. 75% state that they utilize post-operative oral antibiotics, even though we recognize there is no literature to support this habit. 69% or utilize the antibiotics in 25% or less. About 16% of AOFAS members prescribe oral antibiotics after all elective cases. Most commonly utilized is cephalexin, 500 milligrams QID, and the typical prescription is 4 to 5 days following surgery. Looking at the details of the study, 25% of AOFAS members state that they never prescribe oral antibiotics following initial surgery, and as you could see, a substantial number of patients receive oral antibiotics. Very few prescribe it for greater than 50%, but there are a percentage of doctors, as many as 1 in 8, who utilize oral post-operative antibiotics on their patients for all procedures. So it's about 1 in 8. As you could see, about 8% prescribe it for greater than 50% of their patients. Looking at the prescribed antibiotics, far and away, the most commonly prescribed oral antibiotics following foot surgery, they were talking about elective foot surgery here, is cephalexin 500 milligrams QID. Next most common regimen, 500 milligrams TID. Then far less commonly, clindamycin 600 milligrams TID, clindamycin 300 milligrams TID, and cephalexin 250 milligrams 3 times a day. Looking at the conditions under which the AOFAS members elected to utilize oral antibiotics following surgery, I think in speaking to the residents, this probably parallels the same thinking in podiatry. They will tend to give antibiotics if the patient has a history of prior infection in the area. They tend to give oral antibiotics following surgery in patients with medical comorbid conditions such as diabetes, for example, patients who have a history of having difficulty healing wounds, patients who undergo prolonged procedures, patients who have had implants or hardware placed in their foot, patients who have undergone multiple surgical procedures on the foot. Some say anytime I do work on bone, I will give the antibiotics. Some have opined that surgery in the forefoot typically requires post-operative oral antibiotics. And again, some doctors give no antibiotics. Others say, well, if I do hindfoot or ankle surgery, some will give it if a tourniquet has been utilized, and some will ration that patients over the age of 75. Now, what's interesting about all of this is that on surface, these sound like reasonable arguments to make on behalf of giving post-operative oral antibiotics. However, if we look at the published literature, there is simply no support for doing so. In fact, in looking at this particular study, there was no difference in post-operative infection rates between those who gave post-operative antibiotics and those who did not utilize post-operative oral antibiotics. And this is typical of other studies that show no benefit to discharging the patient with a prescription for continuing oral antibiotics, although it's something that we somehow feel would be in the best interest of the patient. There are disadvantages to giving these medications, and we'll discuss that in a bit. So we tend to look at patients that we perceive as being at higher risk for infection following elective foot surgery, and we tend to look at patients who have diabetes, the obese patient, the older patient. We know that infection rates are higher in smokers than non-smokers. Infection rates are higher in patients undergoing emergency surgery, patients who have obvious contamination of the wound, and certainly patients that we see who are on immunosuppressive therapy, patients who undergo prolonged surgical procedures, patients with retained hardware, retained implants, and we say that, or patients who have received a lot of implant materials, such as, for example, an Achilles tendon repair for, say, an insertional tendinosis. And our rationale is these patients are at greater risk for infection, so I'm going to discharge them with a prescription for oral antibiotics, when in fact the literature does not support this, nor does the literature show there's any reduced infection rate. This was a study of post-operative antibiotic use following elective podiatric surgery, review of over 4,000 patients, and the survey looked at reported infection within 30 days of the surgery, and you can see that there was no reported difference in infection rates whether post-operative antibiotics were used alone or in combination with pre-operative antibiotics. There was simply no evidence that administering these antibiotics results in reduced infection rates. Another such study reported at the AOFAS meeting in 2015 out of Chicago, looking at almost 5,000 consecutive patients who underwent foot and ankle surgery, and the patients were divided between those who received an antibiotic and did not receive an antibiotic. And interestingly, in this study, the patients who received post-operative antibiotics had a higher infection rate than the patients who received no post-operative antibiotics. Another study looking at prophylactic antibiotics in hammer toe surgery with K-wire fixation. This was an examination of patients, 100 patients who had hammer toe repair with K-wires. the overall infection rate was 4%, and interestingly, the group that received the antibiotics here also had a much higher infection rate than patients who did not receive did not receive antibiotics, contrary to what our thinking might be. There are downsides to this, and I recall being the expert witness in a particular case in which a patient was having a ganglionic cyst removed from the dorsum of the foot. This was a middle-aged female with no medical illnesses, no real compelling reason to give an antibiotic. The patient received clindamycin intravenously as prophylaxis due to a beta-lactam allergy, and had a reaction to the clindamycin and died. Lawsuit ensued, and eventually the liability was actually found on the anesthesia department. The nurse anesthetist had bolused the clindamycin, and that was the cause of death, not the actual administration of the clindamycin. And what was interesting and was never raised was why the patient had been receiving any antibiotic for performance of excision of a soft tissue mass under local anesthesia with sedation in an otherwise healthy patient. There should have been no exposure probably whatsoever. If we look at the guidelines of the American College of Foot and Ankle Surgeons, they are very clear in their recommendation that antibiotic prophylaxis should be discontinued within 24 hours. And of course the other guidelines one would expect, such as making sure the antibiotic is administered before the tourniquet's inflated, perhaps reinforcing the use of the antibiotic or using the antibiotic for prolonged procedures. And looking at a general systemic review of antibiotic use for prophylaxis in foot and ankle surgery, this particular study is a recent one, very, very recent in fact, systematic review of literature between 1990 and 2018. 11 studies actually qualified for inclusion of this study, and in fact, even the use of any antibiotic prophylactically for foot and ankle surgery is lacking. So we really have no clear evidence that even standard antibiotic therapy is sufficient. It's kind of interesting that we as foot and ankle surgeons are not the only ones that fail to follow guidelines that basically recommend prophylactic antibiotics within 1 hour of surgery and demonstrate no benefit to giving antibiotics following that. This was a study published about 7 years ago, looking at whether or not surgeons of all specialties did the right thing. So they looked at whether or not prophylaxis was administered when needed, was not administered if not indicated. They looked at the choice of antibiotic, dosage of the antibiotic, timing and duration, and you can see that overall compliance in standard recognized guidelines for the use of antibiotics with surgery was only 37%. So barely over 1 out of 3 surgeons of all specialties actually follow the recommended guidelines. So there are, of course, risks versus benefits, and what you might say, well, what are the risks of giving unnecessary antibiotics? And I've listed them here. There's a minor to major. One can have rash, GI upset, certainly pseudomembranous colitis. Again, I did review a case of a patient who had a ankle fracture and received antibiotics for prophylaxis following surgery, developed a C. difficile colitis, and died. So we can get major complications from unnecessary administration of antibiotics. Patients can develop hepatic disease, renal disease, resistant bacteria superinfection, and of course increased cost. And the real question is, what is the benefit? And we have no proven benefit to the administration of antibiotics following surgery. So in summary, while it is commonplace for surgeons, foot and ankle surgeons in this case, to utilize oral antibiotics following the performance of surgery, there is no indication that these are of any benefit to patients. Several studies have shown actual increased rate of infection with the use of these antibiotics, and really no benefit to be derived.